So the program we've got today, and I just wanted to introduce a little bit and see why am I standing here, why as a Health Translation SA involved. And as I said, we're an accredited research translation centre. So what we're trying to do is make sure that the things that happen, the research that matters is actually put into practice, but also the things that happen in health services are done with the rigour and a research lens and using the knowledge and skills and expertise of the research community to help them be as good as they possibly can be. So I think this was a great opportunity for CALHN and HTSA to come together. CALHN came up with a concept of course that they thought about doing a prehab program to actually get people in a much better shape before they go into surgery. HTSA was able to come through and say, this is the sort of expertise we can bring to the table to help build that project. It was around implementation science, it was around consultation, it was around how you work with groups to bring together and shape a project that's going to have the rigour and integrity to make that difference. And that was really the journey we've been on. I think it's actually been a 2-year journey. While Ellie and the team have been doing this for a year, I think Akushla and Jane started coming up with this idea well before that. So we're really pleased to be involved with it. I think another important factor is we've learnt a lot from being involved in this as well. And one of the things that is a takeout from this is we're now running a Research Translation Essentials course. The first course is on, we piloted it in December, and the next course is on September the 25th and 26th, and another one in December. And what it is giving people an insight into a whole lot of the competencies you need to consider if you're serious about translating research into practice. So if you know anyone who'd like to do that course, we'd love to see you. And we're working, the first course is nearly full up, which is great, and we're working towards that December one. But we think we've got the program in that course which really can help many people and help deliver things that matter to people outside the consumers and people who need the healthcare to be delivered as well as it can. So really pleased to be here to hear about the progress of this 2 years of work. And look, I think that's probably enough from me. The program we've got today, Clinical Needs and Co-Design Approach, Jane Andrews and Jackie are going to talk about that. So we're really pleased that they're here and going to be able to present. We've got Implementation Science Progress and the 1-year results from Ellie. And we're really looking forward to that as well, Ellie. And the role you've been able to step into and play has been really important to being able to deliver this. The importance of telling people the story and having those 1-year results can't be underestimated, because you're taking people on the journey all the way. We've got a consumer reflection from Sharon, and that's great that we've been able to have that as part of the program. And then Jane's going to talk to us a little bit about next steps and things that you might like to think about being involved in, and we'll be thinking about, especially online, people who are beaming in from elsewhere might like to think about how they might like to get involved in the future. And then we'll have a panel where we'll invite our speakers along with Ken from Personify to come up and have a bit of a chat, which I'll officiate. So with that, I think you've set the scene for a really interesting hour or so, and I'll introduce Jane. So with that, Professor Jane Andrews is the medical lead of gastroenterology, general and GI surgery in Central Adelaide Local Health Network. And she has got a whole lot of other things here. She's passionate about value in care, clinical outcomes research and healthcare system delivery. And we really welcome her and really appreciate the leadership she's had for this project.
Look, thank you all for coming along this evening. It's great to see all of you who are in the room, because it's really nice to have that sort of energy of presence of people physically here. And thanks also to Wendy, not just for her generous welcome, but also for the support that we've had from Health Translation SA, and particularly also from Akushla, who is an ex-PhD student of mine. There's no escape, we know that. So this is a really exciting program that we're going to talk to you today about, and I'm really proud to be spearheading tonight's meeting. But most of the work has been done by other people. So the ideas and the initial development and persuading people to support us with some funding was sort of where I came in, and then was fortunate enough to get some funding from the Hospital Research Foundation, some support from Health Translation, and also some support internally from CALHN, so that we could actually pull this together. So it's really very much of a group thing. We've also had consumer input and PHN support. So it's really been a group experience. So why would we even think about doing prehab? So I'm a physician and I would go to surgical audit meetings, and an annual audit is compulsory for all units that want to be accredited. And we would sit and we would hear about the bad things that had happened to some consumers, and often they would be things that were not entirely predictable, but sometimes we'd go, oh, someone was still smoking, oh, and they were really seriously overweight, and oh, their diabetes was not controlled, and they were anemic or iron deficient, and they had chronic pain, they were on opiates. And, we sat there going, oh yes, we can see these problems, so do we sit and look at them and try and rectify them after they happen, or do we try and do something about them? So post-operative complications are common. They're a major cause of morbidity and sometimes mortality. The impact to the patient as an individual is terrible. The impact to the system is just as bad, because people who get complications stay in hospital longer. They require a bed for longer, which means that we're doing fewer procedures, fewer surgeries, which means other people are queued at home and they're not able to access care. And it means that care costs more. So nobody's really happy when there's a complication. So if we can avoid them, even if we can only take off 10%, 20%, whatever, then I think we should do that, because it's an all-round benefit to every part of the system, from the individual who avoids the complication, their family, the clinical staff, the bed use, the funder, the taxpayer, everybody wins. The other thing is that complications are going up. Our population is ageing. We have more complex chronic disease in the community. We have more obesity, more diabetes. We have more mental health disability. So this is not something we can afford to ignore. So my background's been in organising more proactive care models, and this looked like a really good opportunity for a proactive care model. So the opportunity was that we could actually see the problem, we could see the consequence, and we could imagine that interventions would make a difference. There was some evidence that small individual interventions did make a difference. Nobody had actually looked at whether a global, holistic sort of bundling up of all the sensible interventions would make a difference. We also had the opportunity to look at digital tools, and at the time, I think it was probably in this very room some time back, I sat near Ken and he was talking about they've got this great tool that can help people in that perioperative period just getting ready to come in for elective surgery. And I'm going, oh, why stop there? We can go right back here. So we started doing digital colonoscopy, triage and preparation. And then we thought, oh, we can use that to do this prehab program. We were also aware, because of where I sat in the organisation, that we didn't have a huge budget. We didn't want to pull in all the work and say, oh, we need 10 OTs and we need 5 physios and we need exercise physiology, because I knew what the answer would be if I kind of went to the people at the next level up and said, I just need another 20 FTE. But we're also aware that in the Australian healthcare system, a lot of these things are accessible. They're not perfectly funded, but there's not zero funding in the community. And the other thing is, most of the rest of my friends and family are not clinical, they're not medical, they're not nursing. And if you talk to people, they say, if I had only known, if someone had told me, I could have. So let's stop locking the information up, let's share it with people. So we decided to have a hospital-initiated but community-based program and respect people's ability to do some things for themselves and also to give them information, so that we could do earlier optimisation of what we call modifiable risk factors. You can't change some things about yourself, but there are a lot of things we can change. The other thing that's important to think about is the surgical journey. Now, sometimes people imagine that it starts at the time that there's an appointment with the surgeon, or what is called the decision to operate. But actually, that's waiting a long time. We know that that initial referral point, where the GP is writing a referral to a surgeon saying, could so-and-so have an operation, or would they benefit, are they suitable? That's the time where we've got a lot of waiting, a lot of passive time, and a lot of opportunity to actually say, yes, no, maybe, and also not just to leave people in a queue, but to say, while you're waiting, would you like to help yourself? And so we decided to get involved right back at that referral point. The other thing that does is it took us away from where all the other activity was. It meant that we weren't going to be tripping over the perioperative people, we weren't going to be tripping over the anaesthetists, and no one else was intervening at this point. We knew from consumers that they were feeling ignored, they were just sort of sitting on a queue, the queues were getting longer, COVID hit, so it made perfect sense to go right back there. And so what our approach was, that we had sort of two components. We had the open access website, and this is the front page of the website that you can see on the left-hand side of your screen, right-hand side of my screen. I'm not very good with that. And then we also had a very personalised invitation to a health screening pathway, and the QR code was actually, well, that was to view the website. The personal invitation to your prehab comes on your phone. Now, in the beginning, we had a few people who thought it was a bit of a scam, but not anymore. We have 80% of people registering, and this is what it looks like. Mobile phone in the centre. On one side is an example of the exercise program, so that's just one bit of information that you may be recommended to have a look at if you say that your exercise levels and activity levels are low. On the other side of the screen, which is on your right, is the My Prehab summary report. So after you answer all the questions, you get a summary report that says, oh, you've told us that you think you would like to optimise your general well-being, your activity levels, and perhaps your weight. And then you're encouraged to print that out and take that along to see your GP, and also to click on the topics that are relevant to you and go and have a look at those. So that's how it actually looks for patients. Now, unfortunately, Jackie Yeo, who is our GP liaison officer in CALHN, rang earlier, and she's got a bit of a family emergency, so she can't present on this co-design part, which is a real shame, because Jackie and I first met in private practice when I used to do private practice as a gastroenterologist before I took on this managerial role, and she was predominantly a GP in a city practice. And we used to do a lot of sort of shared care using text messaging and quick calls and things like that. So when I had this idea that was going to involve reaching in to general practice or reaching out and, you know, talking to consumers directly from the hospital, I thought, well, we really need to find out what our GP colleagues would think about this. And Jackie was really pivotal at making sure that we reached out not only to the GPs through the PHN, but also to her other informal networks. And that's been hugely helpful. We then went on and had really good clinical co-design. It wasn't just with the GPs and specialists. We included a whole lot of allied health practitioners, many of whom are here today, some of whom are in leadership roles and some of whom are in clinical roles. We also had consumers, and Sharon's going to speak to us later more formally about the consumer reflection, but we did also engage some other consumers, and Akushla helped us with coordinating some of that stakeholder feedback in the implementation, which is now published in a full paper. So that's really worth seeing. So we got everybody into the same room virtually or in reality as we were able to during COVID, and we made sure that we understood people's different viewpoints, the different opportunities, the evidence, and then we started collating information to get together so that we could give people information which was felt to be clinically appropriate but also consumer appropriate and relevant. So then we got actually quite a lot of feedback from consumers, which is great, and people validated the importance of being physically and mentally fit, being able to prepare their home environment. We nearly tripped over that one until we had some OT engagement about getting the right devices, and then being fully informed about the journey. And that was something that, you know, when we sit in healthcare, we imagine everyone knows what the journey looks like, because for us it's routine, we do it all the time. But actually, for each consumer, often they're only doing it the once. And so just sharing that whole journey so that people could prepare themselves is great. And then we also saw about some of the barriers that people had had before and how this could help them deal with some of those barriers. So that was really nice. Our primary care doctors, that was really great, some of the feedback that we got from them. There was initial concern that we were going to be giving them more jobs to do, but actually there was a lot of positivity that came out, was saying, look, this is great because you're telling them the same thing we've been trying to tell them for a while, and we can use surgery as the lever to get some behavioural change from some people. We got, that expectation setting, that it was great if we were all singing from the same song sheet. And, you can read some of the other comments there. And we tried to do this in very much a collaborative way, which was taking on, the journey of the willing rather than trying to implement something which was mandatory or was going to be regarded as creating barriers to people to access preparation or additional costs and things like that. Obviously, no program can be all things to all people, but some of this stuff, if we make it easier for the majority, then we have more time into care for the people who really need our help. So then we got some testimonials from various other people, one which was from an LHN, another from a GP, and another from a practice nurse, just reflecting on their experience of actually being taken along on the journey with the co-design. And I think, these are older comments now, but it's really good to see that this background in going a little bit slower at the beginning and Akushla putting in some rigour, because I'm quite good at big pictures and getting going really fast, but it's been a really nice balance and a bit of attention to get it right, and that's been really helpful. So now, having told you how we got here and who was involved, I'd like to invite Ellie Bills to come up and talk to us about the 1 year results. Now, Ellie is a physio, and she came in as the manager, the clinical manager of the prehab program. It was all very new to her, and I must say, she and Anastasia, who's our admin manager, have been absolute stars in implementing this. So Ellie, tell us what we've done.
Thanks, Jane. So I'm very excited to be here today to be able to present our progress over the last year and our results as well for the first year of the program. I just want to reciprocate what Jane just said and say thank you to Anastasia Dimopoulos, who I work very closely with on a day-to-day basis, and she's been overseeing a lot of this data as well as helped put together this presentation. So since July last year, when we first rolled the program out in orthopaedics, we've now implemented it into 4 different units across 5 specialty areas at both the Royal Adelaide Hospital and Queen Elizabeth Hospitals. We've seen across all of the pathways a really high registration rate, and as Jane mentioned before, in the non-urgent pathways, they're just receiving a cold text, so there's no pre-warning about the program. They're just invited to participate from a message from SA Health. All of these pathways include the core prehab information, so that information on the modifiable risk factors, but we've also tailored the information for each of the different cohorts that we've rolled it out into, and we've modified the pathways so they fit into each unit's workflows. An example of this, tailoring of the information has been earlier in the year we collaborated with the University of South Australia Exercise Physiology Program to provide a student-led group telehealth session for joint replacement participants. You'll also notice that we've now expanded from the non-urgent elective surgery into cancer, and this followed units coming to us with interest because they had patients who were receiving neoadjuvant therapies, so that could be chemotherapy or radiotherapy prior to having an operation, and felt it was an opportunity to provide this program to them. So we've worked really closely with these units as well as some of the dietitians, physios and psychologists to make sure that the information is appropriate to this cohort. So as Jane has already mentioned, evidence does exist for some of the individual interventions, but this is the first time it's being tested as a digital approach and also bundling them all together as a package. So we're interested in whether consumers see the program as being acceptable, appropriate and feasible. So consumers are asked to rate on a scale from 1 to 5, where 3 is considered to be more positive. And you can see here at their 2-week feedback that they're overall saying that they're agreeing that the program is acceptable, appropriate and feasible. The bariatric pathway and complex hernia repair currently is slightly more positive in this way. And we've seen that in the 26 participants that have gone through to have surgery from the joint replacement cohort, of those that provided feedback, they're also reflecting on their journey very positively. So we'll move on now to the 1 year results, and I'll be focusing mostly on the joint replacement pathway here. And for this cohort, it's participants consumers who've been invited when their referral was first received, and they've been referred for consideration of a total knee or total hip replacement. And before we go into this, I also just want to mention that in the orthopaedic cohort, this program is now independently run without any assistance from us. And that's largely due to some work from the nurses who've been involved, so Leslie, who's actually here today, and Kate from the RA. So here we can see an overview of our first year. We've had really high registration, with 79% of the nearly 700 people who've received the invite from a cold text message participating. Once they register, there's really good engagement, so 98% have completed the health screen. And this is considered a core component of the program, because following the health screen, that's when the consumer will receive the tailored information. We've had a few patients where the referrals have been declined, and this is a result of this program being actually embedded into the workflow of the orthopaedic units. So once a referral has been triaged, the health screen is actually reviewed, and that's helped to identify 36 referrals that weren't quite yet ready to be put on the wait list, with the primary reason being a high BMI. And then you can see there's opportunities as the program progresses for feedback, and we've had really good engagement from the consumers at that point. So we've seen that there's some opportunities for optimisation of modifiable risk factors in this cohort. The first would be with weight, and you can see that there's a really high percentage of people, so 15%, who have a BMI greater than 40. Over half are actually classified obese in this cohort. We have also a really high prevalence of chronic pain, of which 60% have actually stated their pain is uncontrolled. From the screening, we're seeing that 42% are classified as frail, and it's worth considering that only 14% came out as robust, so being the strongest of the cohort. And then 1 in 5 have got diabetes. Activity levels of participants were really low, with nearly 2/3 either reporting that they are little or not very active. And only 21 participants reported that their activity levels were very fit and active, with almost 70% unable to walk around the block, which is about 300 metres unaided. So as part of this health screen, we're also asking them what their confidence is to improve their health before surgery, as well as how much support they require to achieve this. Nearly 60% were either not at all confident or slightly confident they could improve their health, and this was prior to receiving the prehab information. Interestingly though, a similar amount didn't feel they needed a lot of support, and they could make their own plan or needed a little bit of support, which might have come from their GP. So this graph here is demonstrating the high rate of access for the information that's provided following the health screen. So as you can see, overall it's very high, and 80% are actually reviewing all of the activities they receive. And that's keeping in mind, on average, participants have about 4 modifiable risk factors. So they're not just having to click on one information topic, they might have multiple to review. The top topics that are provided are nutrition and weight optimisation, pain management, and frailty, which based on the previous slide isn't too surprising. I think just to point out that equipment and community services, which Jane mentioned earlier, was something that came out of those initial discussions, is actually something that rates quite highly for the information that's provided, with over 50% not knowing how to access community supports or equipment either before or after surgery. As we move through to the 2-week post-registration feedback, we can see that self-reported engagement is still quite high. We've got 60% saying they've already started to work on the health areas that were provided, and then 30% there saying that they've started, but they haven't started yet, but they intend to, which I think only 2 weeks in is quite appropriate. We can see also that GP engagement is high. So all of the green areas in that pie graph represent that the participant has already seen their GP, that they plan to see their GP, or that they've booked an appointment to discuss the health areas that were identified in that report, or the information that they received. As part of this pathway, we have check-ins, and for the majority of this cohort, at 6 months, they will receive a check-in from us to see how they're going, but it also acts as a point of motivation for them too, and to show them that we're still interested in how their journey is going. At this point, 80% have said they did discuss the information with their GP. 23% have completed everything and they feel like they're ready to go. And then over half are still working on it and it's still in progress. So these are areas that they've identified to us that are important. You can see in green there that's either in progress or completed, and in the orange is the areas that are planned to be worked on. And it's slightly different to the last graph we saw where activity and exercise is at the top, but then similarly pain management and nutrition and weight optimization closely follow. A reason for this is, as I mentioned earlier, we have targeted some of the information for each of the different cohorts. So everyone in the joint replacement cohort, no matter what they respond in the health screen, will receive some information on the benefits of exercise for joint arthritis, and that's for hip and knee. So it's been really pleasing to see that there's actually been no difference between baseline demographics between our participants and our non-participants. And that includes age, gender, the need for an interpreter for health appointments, socioeconomic status, and Indigenous status. The only exception to this is that there's actually a higher proportion of consumers from rural areas who participate. So we had 133 rural consumers invited, and of which 117 have participated, with only 16 who didn't. We can also see here that this is a relatively disadvantaged cohort. So on the scale, on the index of relative socio-disadvantage, which is a scale from 1 to 10, where 1 is the lowest, the most disadvantaged, and 10 is the least, we had 40% in the lowest 3 deciles for this cohort. If we consider the bariatric cohort just briefly, they're a quite significantly disadvantaged group, and we've seen that almost half, or just over half, are in the bottom 3 deciles, and 1/3 are in that lowest decile. So in the past year, there have been 26 participants who've received their operation, whether it be for a knee or a hip replacement, of whom 20 actually entered the program when they were added to the surgical waitlist. And this was something that we implemented around September last year to try and improve access to the program to consumers. So 16 of these had a total knee replacement, and the early data for the knees is promising. So you can see that the average length of stay for the Royal Adelaide Prehab and the Queen Elizabeth Prehab participants is sitting lower than the same hospital for the previous year. And it's also sitting lower than the average for our Health Roundtable equivalent peers. So that's a benchmarking group. We've only had 10 hips who've been operated on in this period, and the data for this cohort currently is quite spread, as you can see. So we're looking forward to more participants receiving their operation to have better insight into the impact of the program. But I guess the initial results from the knees at least is quite promising. So just to finish up, I wanted to share some of the consumer feedback we've received, and there are opportunities, as I mentioned earlier, throughout the pathway for them to provide this. I probably could have included about 20 slides of these comments, but overall the participants are saying that they're feeling supported, they're guided, and generally they're really appreciative of receiving this information early in their journey. There's comments such as, it actually makes one feel like you haven't been forgotten by the system. And I think when we consider the orthopaedic cohort, where there are long waits to see the doctors and then potentially long waits for surgery, this is a really important comment to be seeing. There's also one such as, it gives me the confidence to push. I know there is someone who cares. So I guess on that note, it'd be a good time to hand over to Sharon Coles, who is a consumer representative and a key member of our steering committee, to share her reflections.
Thank you, Ellie. I think it was Jane that said I could talk about anything, so I'm not going to talk about the crows and the gole that that was misdiagnosed. So I became a consumer in the health industry sector about 5 years ago now, coming up to 5 years, which was unexpected. At that time, I was a bit of a couch potato and I hadn't done a lot of exercise. And then due to that experience, I decided that I needed to get off the couch and do a lot of exercise and stuff like that. So that became my goal in life, is to maintain fitness. And as luck or unlucky. I then had a couple of other surgeries coming up that were due to incidental findings. And so the one major surgery that I had, which was just over a year later after I'd commenced an exercise regime and that, helped me recover really very quickly. So when I had that experience like almost 5 years ago, that was when I decided that I'd like to get more involved in the health sector and put the consumer voice forward. And it just happened that this prehab program came up, and which was something that, as I just said, that I was very passionate about. I've enjoyed watching the evolution of the program from the website. I was involved right from the start, giving input into my voice into the website, having a look at all the feedback, and Ellie and Anastasia send out monthly reports, and it's quite interesting to review those reports and do my own non-clinical analysis of the reports and provide feedback on that as well. I think it's, as we were talking about, like there was one comment from one of the consumers. He said that he'd always wanted to give up smoking. It was the push that he needed. And I think that's my thing being a consumer as well, is people just don't really know, that how important it is to get themselves into that optimal care and optimal state. One of my goals would be that I'd love to see this program be something that everybody does like annually or even every 2 years with their GP, rather than just because they're having surgery. So that will be the ultimate goal, I think, for the prehab program. But I think well done to everybody that's been involved, and thank you for having me. And I'll hand you over to Jane. Thanks.
Yes, I did tell Sharon she could say whatever she liked, so I'm feeling kind of quite lucky there. And I would like to acknowledge as well, we've got one of our other professional consumers here, Jan McMahon, who's been guiding us in S3 for some time as well. So thank you for coming. So look, next steps, because, we're restless people, we like improving things, and obviously I think we have hit the right note with this program. I think there are lots of people involved who've really shared their time, their insights very willingly. I'd like to acknowledge Kiri Riley as well, who did the website for us. And, the joint replacement nurses have been absolutely fantastic. I know Ellie did acknowledge Leslie and Kate, but, they took this on, and I don't even, have governance over orthopaedics, but orthopaedics were just great with this. And I thought the surgeons might have been worried or upset. They love it. I've had surgeons pigeonhole me in the cafeteria going, "What was that phrase you used?" And I'm going, "What phrase? What phrase?" And then they go off and use these things, because we were talking about the whole idea of, serving up to the surgeon, putting them in a situation where someone was in the room who was not ready for an operation, but they'd waited so long they were desperate. And so, that feeling that they had to have false compassion for the person in front of them and operate instead of actually saying no. So this allows people to say, actually, you're not ready yet. It also enables people to get ready, and also to pull forward the people who've ticked off all their stuff. And hopefully as we get some more beds and people stop having their winter coughs and colds, we'll be able to really ramp up the surgical activity to get some of those consumers who've been waiting a long time through with their hips and knees, and all the other stuff that's important. So in terms of next steps, we do want to do more, and some of us have already had some early conversations about what else or what in addition. And Liz Sutton, who's the Executive Director for Research in CALHN, Wendy Keach, Akushla, and I've already had some discussions about perhaps crafting an MRFF application to look at doing more concentrated preoperative information for people, to actually running surgery school for people. And this was an idea that came out of talking to our anaesthetic colleagues the other week. They hadn't really heard that we were doing this because we were doing it so far away from their space. And they said, look, this is something that happens in the UK. Could we do it? And I'm going, yes. And they're going, we could pull people into a room. We're going, no, it's okay. We can do it digitally. And so I think we will consider doing that. And also, once we've got people on the pathway and they're doing their peri-op screening and their anaesthetic sort of risk factors, then why don't we continue messaging them in hospital and help them get ready to go home? Why don't we have criteria-led discharge in the patient's hand? I thought you would, and Christian likes it too. I can see the nurses love this one. Yeah, excellent. So we'll be coming to you to talk about this. But, seriously, consumers are the experts in their own care. Now, we can inform and guide and provide. It's a bit like, like I don't do my own financial planning. Surprise, surprise, I go to an expert. But they also ask me about my preferences, what I want to do and how I want to do it. And then they say, oh, that's not such a great idea, and we have a discussion. Why don't we apply this also to healthcare? Why do we respect everyone before they get here, and then once we get here, we put them in a white gown and they're not allowed to have a thought? So, I think this could be a really good idea that goes through. Those of you who know me well know that we're also kind of doing deterioration monitoring in the hospital. We're hoping to implement that soon. So if we see that you're all green on the risk scores and you've achieved all your things and you've told us you've got your equipment, then perhaps we'll lead to self-discharge in a good way, not a bad way. And then I think we could tie that into rehab. So continue the right activity as people leave. So hopefully the relationship with Personify, our consumers, the PHNs, Health Translation, CALHN Research can continue, because I think that we could tie this all up with a lovely big bow and take it a bit further forward, because we've already got the basics there working really, really well. And, credit to everybody. And I think we're happy to take some questions. Oh, I'm sorry. I didn't do the team slide. Now, we all were a few years younger, but most of the people are actually here in the room, apart from poor Jackie, and also Catherine Collins is not here in the room, neither is Anne. Otherwise, this has just been a pleasure to lead this group. Everyone has been so fantastic. Thank you.
Okay, if you're a speaker, come on up. And I'd like to invite Ken from Personify, whose name's been used in vain a number of times, to come on up and actually talk for himself. The other thing I wanted to say, especially for the people online, as Jane's next steps about MRFF grants and thinking big picture, I would like to encourage us to think the things that win these grants is when we look at scale, we look at how we actually reach outside of our state borders. So I'd like to think us, and anyone online who's listening to me, think about you might like to get involved. We might like to think big picture about this stuff. So let's keep ourselves too a South Australian focused. Obviously, we've got lots to deliver in South Australia, so don't get me wrong, I'm here. But let's think that big picture as well. But congratulations to all of you on those presentations. Congratulations on the journey you've been on, and that the data that you've been able to share with us, Ellie and Anastasia, thank you. I'm really interested to look at those, the so what happens as it goes on, and only time can tell with that stuff, what is the impact has over time. So really looking forward to that. But I'm going to start, and I think there is a mic there, and the button, if you like to grab it, Ken, and push the button up. It's on the side, and push it up. Yep. Is it just have a chat? Oh, there you go. Okay, Ken's going to give us a very quick, the Slido thing. Okay, first of all, while you're talking, I'm going to leave this slide up, and anyone who's got a question online or in the room, please pop it up there. We do have roving mics as well, so people in the room who'd like to ask a question, please just go for it in a moment. But if you're online, please send it through, and we'll certainly work on those. We've got about 15 or 20 minutes for questions, so please, I'd love to see a nice, vibrant panel. But first of all, I'm going to ask Ken to introduce yourself, and also just give us a little insights into the role you've played in this project.
Yeah, thanks, Wendy. So my name's Ken Simone. I'm the CEO of a company called Personify Care. We're a digital health company that started around 8 years ago now. Just hearing some of the talks today made me reflect around how our involvement in this project went back a couple of years. But we started with a basic problem in mind, which was how do we connect patients to the information and the care that they need before and after their face-to-face encounter with their clinician. And it's a real privilege to be involved in this project, given what the team has achieved. And really, we're just an enabler. So we provide the technology platform that lets clinical teams now around the country in Australia and in New Zealand, both in public and private settings, to convert clinical models of care into what we call a digital patient pathway that's really designed to allow clinicians to take the lead on designing their models of care and provide it in a way that's really easy for consumers to access across all demographics, age groups and cultural backgrounds, in a way that allows them to access the information that's really tailored to their needs at a given moment in time. And so it's a real privilege to be involved in this project.
I did notice the first question just popped up, so I will take that one, and you can keep the mic in your hand. And this is probably a tricky question, but how much does the technology cost? I don't know how you answer that really, because obviously there's projects and things, but can you just guide us a little bit around the sort of investment? How would you do that, Ken? You're clever than me.
If one of my team will be happy to give you a quote, but no, on a serious note. So we deliver the platform as a software as a service. It's licensed based on the volume of patients that need to go through one of those pathways, and then the number of staff that need to be supported in their journey to build these pathways and deliver these models of care to their patients. So it's a licensed model charged on a monthly or annual basis based on the volume and scale of the pathways that are being delivered.
That's great, thanks for that. We've got a question down the front here. Yeah, please.
It's not, cost alone is completely irrelevant, really. It's cost benefit and it's value. So what we've found is that as Ellie and Anastasia have gone into the various clinical areas, they've been able to deliver some efficiencies in terms of the way things are handled. So some people then don't wait, and some of the paperwork management is easier because it's digital, it's not paperwork anymore. So cost alone is not the thing, it's really kind of doing your whole return on investment sort of algorithm. Obviously, the cheaper the license, the better, but it's not cost alone.
Yeah, I think it's a really good point, and we've always got to have that eye on the benefit. Sometimes you have to spend some money to actually get that benefit. Lee, did you want to make any comment there? You've got hands-on experience in the benefits and people. I guess my question to you, and then I'll flick to these ones, is the thing I wasn't seeing in there is we give the information to the people, they do it, you went back at 6 months' time. Is there anything, do we know what happens when they get to the surgery? Have we got a point where we can record or ask questions at surgery and then afterwards about the platform and how much they used it? Because I can imagine they might go through it all and then not use it. I mean, I just wanted to get a bit of a sense from you of how much is it really taken up?
So I guess through the Personify program, we can see who's been accessing the information, we can see at what points they're logging into their account and reviewing things, completing the feedback and completing the check-ins. And we have those check-ins continuously until they go through to have surgery. As I mentioned, there has only been 26 participants in that year period who have had surgery. But following surgery, there is 6 weeks post-op feedback, and that's where we're using that as an opportunity to evaluate the program further, to get further insight into what they've actually been working on, if they found it useful, and whether they think the program is a good fit.
That's great. That's what I wanted to know. Everyone okay? Okay, we might go to the top question on the list there. Thanks all for the effort and excellent results. Will there be any facility for interconnectedness with the EMR so that data and participation are are visible centrally? Anyone want to tackle an EMR question?
Yeah, I can take that, Wendy.
Great.
Very excited to share that SA Health approved integration with EMR. So any data we collect with.
That's a clap moment.
And that's a trend we're seeing across the country, that as some of these pathways have rolled out, we're feeding the data into the source of truth, the patient record, and often that's an EMR, and the ability for that data to be visible to any clinician within the health system is really important as part of these models of care.
What would that look like for this project though?
Well, it could look a number of different ways, because putting it into the EMR is really important for the individual patient and the clinician who is seeing that patient next. However, the other thing about the data is having the data in a way that it can be sliced and diced and analysed, and the data fields are all structured, the definitions are right, and that we can learn with data insights at scale. So one of the other things about getting it into, it doesn't really matter about it being in the EMR for the scale point, but having it in a structured way that can go to the digital analytics platform and then be available to match up with a whole lot of the other South Australian health data sets, so that we can start looking at value in care, and we can start looking at, you know, cost benefit and return on investment and things like that, and help predict who's going to do well from surgery, various characteristics, where we might need more resources to help people, all that sort of thing. So it's individual data in the EMR from an individual patient, but then it's also having the data in a place where we can actually analyse it along with all the other rich data sources in health, because we collect a lot of information. We've wasted a lot of that in the past.
Yeah, it's a really interesting point, isn't it? How we do get that integration. And I think one of the next questions is actually coming up in that way. Can the information gathered be used across local health networks, e.g., i.e. viewed by clinicians at multiple sites? So potentially once it was on the EMR, it could be.
It depends on how your EMR is set up. I mean, obviously in South Australia we've got one instance of the EMR. So if we do put the data into the EMR with integration, then we will all see it. At the moment we're scanning in the personified questionnaire. So it's visible now, but it will be much better if it's not a picture, if it's actually structured data fields that appear.
So work in progress there, but obviously the vision's there, which is great. Now we're going to come up to the back. We're going front row first and then back row.
Leslie from Orthopaedic Surgery
Units.
Great. She's been using it since the get-go. So we have a triaging system. We have a stamp that says prehab program. So when we triage that referral, when it goes into the system, the health assessment, once it's completed, goes up into that referral point.
Right.
So then they're available then when they are eventually seen in their clinic.
Great. So it's really becoming an integrated part of your practice. Yep. And I think we've got, thank you, yep, down the front, yep. Up.
I just want to say thank you and congratulations to you guys, because I've come from Queensland. My name's Mandy and I'm a dietitian by trade. I'm a part of the steering committee. I wanted to say my experience in Queensland is that the health professionals like to, in the hospital setting, like to bring in the resources and manage it from a tertiary perspective. However, I think the unique and most attractive thing about this project is the fact that it releases the resources back to the community, where the patients don't have to pay for car parking and they don't have to do all the things that are associated with a big hospital, and they get to go in their community where they're most comfortable and they're able to see the people that know them best. And the GP connection has been truly the most remarkable part of this project. So congratulations, because I don't think that any of that would have happened without, you guys pulling this together.
Great. Thanks so much for that comment. And I completely agree that if we're going to get an integrated system, we have to work on it and build for it. And if we keep everyone wanting to keep their own little pots of money, we're not going to get there. So I agree. Congratulations. I'm just wondering if Sharon, would you like to make a comment on that one? Just because obviously that integration from a patient perspective, that integration with the GP is super important.
It is, because otherwise you're left wondering, where do you get the information? The resources on the website are really good, and that's a start. And then having that go-to person, which is the GP, is perfect. Yeah.
Thank you. Any other questions from the crowd? Yeah, Liz, you've got a mic.
I've got two, but I'll stick with one. I was really interested in the data about the GPs, because GPs are really important and people claim that they have difficulty accessing them here. They sound fantastic, it is not. And what the slide showed, and I don't know if you know this, but I was interested, people were saying that they were going to their GP or were planning to go. Was that because they were incidentally planning to go, or the prehab program prompted them to go because it incentivised them for a different reason? So was the visit to the GP incidental? Do we know that? Is probably my question.
Ellie, come on down.
So we probably don't know exactly. Some of our messaging is, you may want to take this to your next GP appointment, but we also encourage them to discuss the findings with their GP for some more support. So we don't know exactly if they're returning for that reason or if it is an incidental one.
And I guess the other bit is that they would be the referring GP, although we know in the world of general practice, people roam around a few different GPs, even if they are in the same practice. So I guess there's a few uncertainties in that GP space. Did you want to make a comment?
I think it is a bit uncertain, but one of the things that I think is good about this is that the response and the registration is happening really as soon as the referral arrives. So Leslie and Kate are really good at keeping up with their referrals in week. So they're not sitting around, and so I think that people are going, oh, yes, I'll do something about that. And just anecdotally talking to people, they do get that trigger, and I think when the activation point is close to something else they've already done themselves, so they've just been to the GP and been referred.
Mm.
I have to say, I must be, since the
Can you just grab a mic?
absolutely amazed at the uptake. Absolutely amazed. I wouldn't have thought it in our catchment area, but I have been absolutely astounded how many of them respond instantly.
Look, I think that's really interesting because we had a little bit of a preparation piece that we used Personify Care for colonoscopy, and we rolled that out in Easter 21, so it's 2 and a bit years ago, and we rolled it out predominantly at QE, and QE have been amazing, and people said to me, oh no, it's a low socioeconomic areas, people won't do it, blah, 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 and we had a few people who thought it was a scam early on. No, we did. And we kind of thought, well, who's going to scam you to take bowel prep, really? But actually, it's been really good. We've had thousands of people do the colonoscopy stuff, and now we've had nearly 1,000 people invited to prehab across the 2 sites. So I think what we have been doing, and also there've been the peri-op pathways that have been using Personify as well. So I think we've actually now got some community awareness and expectation, and also GP awareness and expectation that this is likely to happen. And so I think that it's just been one of those really good timing things. Yeah.
Great. So I think we're going to go one question here and then we'll go back on my list. So.
Yes, thank you. I'm coming from the consumer representative position, so thank you for that. This very much excites me, this whole idea. Sharon, thank you for your presentation, and thank you for embedding that consumer voice right within, and thank you for the team for embedding Sharon's voice and her experiences within the team. A couple of things, yes, I agree. I think we're seeing a major shift in that area, and that's great. A couple of things that do occur to me. Love Personify. I've been part of that process and find that super easy. Couple of things. Great for rural and remote people who just can't get down here, who may have to travel many hours, potentially stay here and so forth, so the costs are great. So the other thing is, Jane, you talked about cost benefit. I know from my experience over many years, the one thing that lights up the eyes of the executive and politicians is, give us the facts and figures in cost saving. So is it too early at this stage? This is the 1-year evaluation and not a huge number of folk. But do you have a sense, and I'm just thinking in the work that I've done over the years, it would be great to be able to say, one thing that I do know they look for is, do you have a model? Yes, you do. Is it working for consumers? Yes, it is. What are the cost benefits from it? What are we saving over time? So is it too soon to evaluate the cost benefits?
I would put money on the cost benefits. I would invest personally, and I have. I have spent many hours beyond my paid job, and I've put my reputation on the line to go out and seek funding for it. So I've voted with my feet already. I'm very excited, although they are very early surgical data. What we know is when you see a difference with small numbers, the difference is probably real, because what you usually see with small numbers is no difference. Yes. And I think we've already got quite clear separation with the knee replacement stay. The hips, there are smaller numbers of cases that have been done, only 10, and there's one outlier who may have skewed the data. We have to wait and see. But the other thing, and there's some other data that Ellie didn't have time to show, is that people on average have had fewer complications than historical controls. And we know that it is complications that lead to longer length of stay. So I think the early data are very encouraging. I think they certainly warrant us, persisting with the approach. I think the other thing is that there are gains that are more than just financial, and I think that is important to put a value on. So quality adjusted life years, things like that, I think they're important to attend to. I think, as you highlighted, the lack of travel for the rural and regional people, but still being guided through the right process. So we could go and cost all of that indirect healthcare that has been avoided. I think that people have voted with their feet on it. I think that it just makes sense, actually, doesn't it?
But I think in the future it would be worth thinking about some economic modelling and sort of a health economics approach to it, to actually go through all those things and actually do the numbers. And I think it would be well worth, as part of the future, and those next steps bit, thinking along those lines, because I completely agree with you. When you can start to quantify those things, as well as the non-financial benefits, you actually start to really stack up that business case, and that's probably where we can really start to go in the future. Yeah, sure. We need a mic for the people online, please.
The other big benefit from my perspective is debunking some of the belief around people won't access the technology at the website and self-initiate. So I think that's the other really interesting evidence we've got, that people, despite where they live,
are embracing it.
They do access it, they do self-direct.
Yeah, and they're embracing it, and I think that came through really clearly, didn't it? That the number of people who did take it up. So really, really good. Thank you. Okay, we're going to go to one of the questions here. Are you looking to open this program up to all types of orthopaedic surgery, or just lower limb joint replacements, e.g. shoulders, tendon repairs, etc.?
Look, we've been working with the groups who are ready, willing and able. We went with the lower limb surgeries first because they're high volume, and we thought we would get our evidence first in stereotypical high volume areas. But we're going for any part of the program that's willing to join in. There's always a choice between whether you make it very specific to that cohort of patients or whether you keep it a bit more generic. So, eventually we want to get this sort of approach available to all people who are presenting for possible surgery.
Maybe, Ellie, could you just how tricky is it to adapt it? When someone rings up and says, okay, we want to do it for shoulders now, is there much adaptation? Can you just tell us a little bit about that practical thing from your perspective, what you have to actually do?
So I think, I guess the other thing with the hips and knees is that it was a very clear pathway and very defined, both in our medical record system from a data perspective as well. And so I have had a few initial talks about things such as the shoulder replacements and new tendons repairs, because they are those category 3 surgeries. I guess they have a less defined pathway at the moment, so they're kind of all bundled together. And it would just take a similar approach in understanding what the clinical workflow is, and then mapping that out, and then we'd be able to easily bring in the same information across to this cohort. And I guess the other thing is just also making sure that you've got that unit on board, because at the end of the day, we're helping to facilitate and to set it up, and then as we've seen in orthopaedics, they then take over with the joints. So definitely something that we'll be looking to do.
Yeah, I think it's a really important model, that model of actually empowering the people who actually are guiding the service to own it, and then still provide that ongoing support, but you're not doing everything for everybody. You're actually passing on the...
with the sustainability is having it built into a service instead of added on, because we don't want to add costs and add staff. We want to build things in and simplify and digitally declutter.
Yeah, thank you.
The point would be who's going to add them to that list.
Yeah, And it might happen organically, by the sounds of it, a little bit as we build the publicity and the evidence around the things that are happening. I think that's it. Okay, we've got our lucky last question. I can see that we've hit time, so I will do one last question because I think it's a good one. Are you tracking what community services are being accessed, e.g. exercise programs, etc.?
No. So I think that's a really important question. But, you know, it would be great, but we can't be all things to all people. We've got a financial limit. We need to use the grant funding that we've been given in a way that's going to get the best bang for that buck. So we're dealing with it from a sort of a hospital-centric point of view in that way. We can't see the referrals we don't get. We can't see the things that people don't do. But we will be able to get that feedback from people post-operatively and find out in a qualitative way what they found was useful, what they found wasn't useful. We're planning to also do some GP feedback so that we find out what the GPs felt was useful and not useful. We can track the website traffic and the resources that are accessed through the website and what's accessed through Personify, but we can't do everything.
If I just add to that quickly, so because we have this collaboration now with the University of South Australia with the joint replacements, we are getting data from them on the numbers that are accessing the program, and we've now embedded some feedback into our pathway to see whether the participants are finding it useful and if they are attending. And what we've found is since March when we implemented, I guess, the information slowly so we didn't overwhelm their system. But now they're booked out through to the end of the year for their sessions, and we're finding that participants are actually attending all three of the sessions, and the feedback that we've seen on our end has been very positive. And I guess the other side to that is we are linking with community programs, but I guess in the cancer cohort here too, we've been able to connect the dots to programs that already exist within CALHN. And one of them is, for example, the Move Through Cancer program that the physiotherapy department run, that the units that I spoke to wanted a face-to-face prehab program, and then I was able to say, well, this actually already exists, and we're able to now link, I guess, the units to know that this exists, and we can track whether these participants are attending that program as well.
Fantastic. Look, from my perspective, listening to this story tonight, there's a whole lot more work to do. There is opportunities coming, you know, from all sorts of directions, but I think we have to be selective, but we also have to be thoughtful about what are the pieces of the story we want to really measure and evaluate well. And I think there is opportunity to put together a big grant which could actually, knock off a few of these areas and really collect the data, because it sounds to me like it's got GP acceptability, consumer acceptability, clinician acceptability, and my guess is it's actually going to have economic benefits for the system as well. Look, with those final words, I want to just say thank you so much to the panel. Thank you for your contributions in pulling together tonight. Thank you for everyone online. I hope you've enjoyed it as much as I have listening to this story, and for people coming tonight. And we do have just a few more nibbles and drinks if people want to stay around for a little bit longer. But congratulations, and we look forward to year 2. Thank you.